on the slide, Adam Finn, also Catherine Hyams, who is the adult respiratory doctor that's leading the research under my supervision, which has actually been going on for more than 2 years now here in Bristol. Lung infections or pneumonia, other kinds of infections of the lungs are a really big health problem in the United Kingdom and around the world, and they get much worse and more frequent as you get older. Actually, the UK, despite being a wealthy country with a very good health service, has some of the worst patient outcomes if you compare us with other similar countries around the world. And the costs of lung infections are absolutely massive. Even before COVID caused things to get much, much worse, we were spending a fortune, nearly £1 billion a year, as a result of these infections. And of course, COVID's only made it worse. But the use of COVID vaccines have really shown quite clearly that if you've got effective vaccines, you can give them to adults and really make a difference. And the post-implementation studies we've done have really shown a massive impact, not just on deaths, but also on hospitalizations and serious illness caused by COVID in elderly people. And this points to the fact that we could do much better against some of the other infections that cause elderly people to get sick with lung infections. And we're not doing as well as we could be at the moment. Now, in addition to vaccines against bacterial pneumonia, which we currently use, there are new vaccines against those kind of bacteria now available already, but not being used. We obviously have flu vaccines that we use, but don't give to enough people every year. And now there are a whole bunch of new vaccines against other viruses, in particular respiratory syncytial virus, or RSV, which are just coming through to licensure in the course of the next year. And the JCVI that people will have heard about, the committee that makes recommendations about vaccines, are going to have to make decisions about this in the relatively near future. But in order to make those decisions, they really need to have good evidence about these vaccines, about their impact in the real world. If you give them to people, you know, how many fewer people die, how many fewer people end up in hospital, and how big would the savings be for the NHS, which is what drives these decisions. And also how much less illness can we see in people who are not sick enough to end up in hospital, but still get sick with these infections and end up seeing the GP and having a miserable time. And overall, there needs to be a calculation of the economic impact, which is what drives political decisions on things like vaccines. So our idea is to do something entirely new, which has not been done before, and that is to take one of these new vaccines. When it's been approved by the licensing authorities, which is called the MHRA in the UK, so it's a licensed vaccine, it's not still being researched, but at a point where it's not yet been adopted by the government after JCVI recommendations, because that takes some period of time. In non-pandemic times, at least, those decisions often take several years. And what we propose to do is to get grant funding in order to be able to buy the vaccine from the manufacturer and deliver it through the GP system, through the NHS, free, and the normal way you would for a vaccine in Bristol, so just to the Bristol population, and then do continuing detailed research studies that we're already running actually in hospitals and 6 GP practices in Bristol, which enable us to measure the effectiveness of the vaccine. And that would enable us to give the evidence to JCVI so they could make a well-informed, rapid decision on the vaccine for the rest of the country. And of course, we can also publish those data so that other countries and other jurisdictions can also learn about the vaccines and make their decisions as well. Now, doing this would involve quite a big partnership of people. It's not just doctors like me in the NHS working with the university. We'd need to have a real partnership with the community in Bristol. People would need to understand that something was being done in Bristol that was different from everywhere else. And we'd need to know that they were in support of that. We clearly need all the branches of the NHS, the hospitals, the GPs, NHS England, who actually do the commissioning of all of these services. We need the support of the local authority and the UK Health Security Agency, or the public health agencies that oversee all of this kind of activity. We clearly would need cooperation from the vaccine manufacturer. They would need to sell us the vaccine. And in fact, they are already supporting the detailed research we're doing in hospital, the gathering of all of the information, and they would need to continue to do that. And we'd need support from government research funding bodies to pay for the buying of the vaccine and the delivery, so that this wasn't extra work for the NHS in Bristol that wasn't being paid for. So all of those things are needed. So that brings me to my last slide. I'd really be interested in anyone who's on the call to contribute to answering any of these questions that you feel motivated to. The first big question is, do people agree that this is a good idea? I mean, is it a positive thing for Bristol to work in this way, to do something novel and different? Or are there reservations about Bristol being the place where this kind of work was going on? I think we need to understand that. Any thoughts about the partnership of all these different bodies that I've explained? Does that seem workable? Does that seem like a good idea? Really important is the third one is, what's the best way to communicate about these ideas and to make sure everyone really understands what's happening? Really don't want to be in a position where things are going on in Bristol that people don't know about and don't understand, or have suspicions, or, feel might be bad in some way because they haven't had it properly explained to them. And fourth is really, in particular, we want to try and do this work as a means to improve health equity, to be able to communicate, particularly with those areas of the community where there's less trust of health service, there's poorer vaccine uptake, there may be barriers to communication around language and so on. And then fifth is just sort of any other thoughts that you've got that we could learn from. So I'll stop there. I might leave that slide up if that's okay, Carmel, just so that people know. And if Sarah, or I don't know if Ed's come back, but if Sarah's, well, I think Sarah, you're our one guinea pig.
Okay. It's quite good that it is me, because I worked in the pharmaceutical industry 30 years.
Fantastic.
And I'm assuming this is either going to be Novartis or GSK who are making this. It'd be nice to know if you're able to tell me, because I can, having worked for all of them, I can tell you how they might liaise. So I have no problem working with most pharmaceutical companies, and I think it's the way forward. It's certainly what they would want, and they should be providing vaccines at cost. And that this is very much, if they're not providing them free, but there are other issues when you start providing free drugs, and that's another issue. So do I think this is a positive thing for Bristol? This is one of the best research projects I've had explored since I've been a public contributor. It's one of the most important, and I have seen a lot over the last 4 or 5 years. And really, I think it's a feather in the cap of Bristol if this ends up being done centred here. And Bristol, because it is a multicultural, forward-thinking community, and I think Bristol would embrace this and act quickly. So I have no reservations about Bristol being the place. My family lived there and worked there. My son works in one of the big warehouses, which is peopled by Somalis, Romanians, Polish, Ethiopians, all sorts of people who are disadvantaged normally. And there is a lot of those working in Bristol. So the partnership idea, my biggest concern is usually to do with local government, because they can be slow. But I think they should. We've got a really forward-thinking mayor as well. And hopefully the blocks in the system won't come from the national government. I don't know much about Steve Barclay, but hopefully the government would support it. Best way to communicate, actually, every time I watch the news, which I don't always get through the news, but I do usually come alive again, wake up again when the local news comes on after the main news. And that, I think, is a really good way to reach people at 6 o'clock and at 10 o'clock, or 6:30 and 10:30. And I think they would, we want to ask for more than just 5 minutes. We want them to adopt it as an awareness program, and I think they might, although they're health guys, the brightest. No, anyway, that's by the by. So ways of reaching other sections of the community. Carmel has done so much work on this, and so is the team at the ARC. So hopefully that can be done. And I think a lot of it, the information needs to be in lots of languages, in GP surgeries, because that is somewhere that a lot of people access. And I was sitting in a surgery waiting just for a routine thing the other day, and saw something that I'd never seen before on the little television screen. It was muted, but actually that's quite a good way of, convincing people that there's something out there. So wholehearted support from me.
Great, Sarah. That's fantastic. In terms of the companies, the current program of work that we've got going on, which is just surveillance of pneumonia, lower respiratory tract infections in hospital and in the community, is funded by Pfizer, actually.
All right, okay.
So they have both a new pneumococcal vaccine, which is licensed but not yet in use in the UK, but also one of 3 companies with new RSV vaccines. The other 2 are, one of them is GSK, as you mentioned, and the other is actually Janssen, which is Johnson & Johnson.
Oh, okay.
And
I worked for all 3 of those, and I retired working for Pfizer. So
that's very
actually,
interesting.
they are much better now than they were when I first worked for them in terms of altruism and transparency. And all those companies are good in that regard.
They as you say, they're all really working hard, and they've all actually expressed an interest in this program. You're completely right that there are issues around them offering free vaccine, both from their side and from ours, and so that does need to be done through public funding. And what we're doing at the moment is applying to UKRI for a fellowship for Catherine Hyams, which would include the funding for the at-cost purchase of a vaccine, as well as the delivery cost. So that would be publicly funded and would get away from that potential problem of anyone imagining there was something, irregular going on with donations. But the really expensive part of this work actually is the army of people that collect the data in a systematic, prospective way. What we've been able to do with the program so far is to actually show that the burden of lung infections in adults, particularly elderly adults, is more than twice as big as anyone thought, because it just wasn't being coded and counted properly before. So we've already uncovered that fact, and we're coming into publications on that. But the other thing that happened during the course of the pandemic was that we suddenly discovered we've got a machine that we could use to evaluate the effectiveness of the COVID vaccines, because we're seeing lots of people coming in with pneumonia who either did or didn't have COVID, and we could count the proportions of those people who'd had the vaccine or not. And we were one of the first groups to publish and actually present data at the very beginning that showed that both the AstraZeneca and the Pfizer vaccines were preventing deaths in the elderly. So yeah, we've got a great program already going, and now we're thinking of ways to try and improve that.
One of the things that happened, I think, with COVID, that perhaps people, when you work in the pharmaceutical industry, you do really get a much better idea of what's going on nationally, usually England and Wales, not necessarily Scotland, which strangely enough, bodies in the NHS don't always know. And so one of the things that I noticed really early on is, and Swindon for some reason was quite vociferous at this point, but doctors were picking up things like using a steroid, sharing it really quickly. And I think nationally, that the powers that be suddenly thought, these people do communicate with each other and they can act really quickly, and we don't have to wait for NICE to deliberate for 3 months, 3 years, whatever, with a committee of 25. And so I think the thinking has changed in terms of the medical community and how they are able to actually be fleet of foot. So I'm hoping that that will prevail, and that you have this opportunity with this to be equally fleet of foot, because you can communicate with your respiratory colleagues really quickly, and things can change. And they allowed things to change much quicker with COVID. So I think I would be riding on that bandwagon quickly to say, that was shared very fast. People started using steroids, it really made a difference, or people were, pronating patients or whatever it was, but the communication happened. Actually, it happened through the community of doctors, didn't it? Far more than any other communication system. And I think that is, so going back to your communication about ideas, I think you've got a message there that says doctors actually can communicate quite quickly through their journals and their, societies, whichever their specialism is. So hopefully the government will be ready for slightly more swift action than is usually the case.
Yeah, that's really helpful. Thanks, Mike. Do you want to?
Yeah, just I've made a load of notes while you were talking and asking those questions, Adam. And Sarah's answered. She's made a lot of the points that I was thinking to make. I mean, the main one about Bristol being the kind of representative population of the whole country, I think is a key one. And the fact that we've got 2 major hospitals and a few satellite hospitals, we've got 2 universities. And as Sarah said, Carmel's been doing a lot of work around reaching the kind of populations that as health research organizations, we don't necessarily reach very well. They've always been, we've called them hard to reach, but we've taken to calling them easy to ignore rather than hard to reach, because as Carmel's shown, if you put a bit of effort into it, they're not that hard to reach. So I think that's a good thing. And as someone rapidly approaching middle age, and a great advocate for vaccines, I kind of think it's a great idea anyway.
Thanks, Mike. Yeah, that's really helpful. And
I was going to say Bristol Health Partners is probably another team that you need to get on board, because they will have access to lots of organisations and people that we don't necessarily have.
So I should have put that in the slide, Mike. So Bristol, one of the hits, Bristol Health Partners is the so-called Big Hit, which is the Bristol Immunisation Group Health Innovation Team, and we convened a meeting through the Big Hit of all those relevant people. Sarah raised the issue of local government, and in fact we've got Christina Gray, who's the public health lead for the local authority, very much on board with this. So I think we've got everyone engaged to some degree already, and we're using Bristol Health Partners as the vehicle for that, because it is, as you say, an apparatus that's designed.
Exactly this kind of thing. Yeah.
That's the idea. So we quickly wised up to the idea that we really needed to organize this through that agency, essentially. Carmel.
So I just wanted to ask a question on whether you've thought about the potential risk of causing more distrust particularly in like Black and ethnic communities if something was to go wrong, or so it's really clear you're not developing a new vaccine. This is a vaccine that's been approved, but you are I guess not kind of like cutting out the middleman, but you're getting there quicker basically to delivering it to the patient. And from the work that I've been doing with the communities, there still is this huge distrust. So I think it's really great that you're recognizing we need to consider how we work with these communities and involve them in this whole process to ensure that you do consider these things. But I just wondered if you had any safety netting or any kind of support around if that was to happen, like what would you do, if that makes sense?
Sure, thank you. I think this is a vastly important point. So even before we get to that scenario, I think there is a potential for a lot of misunderstanding and indeed some negative messaging if we're not careful, along the lines of you're experimenting on the people of Bristol with funded by a pharma company. People are guinea pigs. They're not giving any consent. I mean, you can imagine pretty catastrophic conspiracy theories breaking out around this if you don't communicate it right to the right people. And I'm very anxious that we do think in advance about that and avoid falling into that trap. And I think the way to do that is to be proactive and transparent and not in any way allow the situation to develop where people somehow uncover what's going on because they hadn't already been told. So it needs to be clear, what's going on, why it's going on, and that there is genuine support. People aren't having stuff done to them that they didn't really understand or know about. Now, in terms of the idea of something going wrong, I think what could go wrong is that these vaccines might conceivably turn out to be less beneficial than they were sort of hyped up to be based on the data we've already got, the phase 3 data. In general, I have to say, what happens when you put a vaccine into the real world is that it turns out to be more beneficial than was estimated by the studies, because there are indirect effects on onward transmission and so on. But we also have seen with the COVID vaccines, excuse me, unexpected rare side effects coming to light once you started giving them at scale. So that is something that can happen, and indeed does occasionally happen with vaccines. You typically in a phase 3 study, you'll be giving the vaccine to tens of thousands of people. And so events that only occur in 1 in a million people don't come to light because there just haven't been enough people given the vaccine. And if you do the study like this in Bristol, you would at least be matching those kind of numbers and potentially exceeding them. So getting up towards maybe 100,000 people, certainly half of that, 50, 60,000 people would be receiving vaccine in order to do a study like this over one winter season, if you were offering it to everyone over 75, let's say. And then if you broaden the age group, that would increase. So there is the conceivable possibility that something happens, that somebody gets sick. And when this happens as a rare event, as happened with COVID, it's not immediately clear whether it's anything to do with the vaccine or not. People get sick all the time, and it's only when a pattern begins to emerge that you can infer that this is a rare event around a vaccine. So all of that needs to be thought about and communicated. And we also have to be completely clear that if we do turn something up, that would be, we would be the first to report it, acknowledge it, and of course, ultimately prevent people from being harmed by a vaccine, if that were to be the case. Now, the other thing around this is that the vaccines that we're thinking about using in this program are not novel vaccines. That, with the COVID, we had these new vector vaccines and the new mRNA vaccines, which had never been used before in people. So perhaps it wasn't, in a sense, that surprising that some new and unexpected things turned up. The vaccines that are coming through for RSV and the one that exists for pneumococcus, these are vaccine platforms and technologies that have been used already for a very long time. So it's quite unlikely that something rare would show up in that way, because we've got a lot of experience of using these kind of vaccines already. But nevertheless, you're completely right. And it seems to me critical that we do what Mike was suggesting, really. I go on Points West, do the local radio. Everyone knows about it. I think Sarah, I'm sorry, was perhaps saying this. And also the idea about communicating in GP practices in multiple languages, putting little films up that people can watch. I think everyone needs to know that this was happening, and preferably be proud of it and be part of it, and own it, and know, particularly for those, now Mike got it right. He didn't say hard to reach. He said, what was it?
Easy to ignore.
Easy to ignore. I mean, I think it's really, those are the, I'm not just keen to try and extend the reach of our health interventions to the people who most need them. I'm also really keen to avoid the situation where we compound distrust and make things worse by doing things that are novel and different, and people don't really understand, and or even don't even know about what's happening. So I think a big part of our efforts would need to be invested in making sure, in every which way we could, with experts like you, Carmel, how do we make sure that people understand and aware, and ideally, if possible, are bought into this and proud of it and part of it, rather than suspicious.
We were talking, oh, you go on, Carmel, you're going to speak here, aren't you?
I was just going to say thank you to Adam, because yeah, I think you answer those questions really well, and I'm really glad that that's your kind of thinking moving forward. So, and obviously I'm here and really happy to support you as well.
Well, we'll use that, don't worry. We'll be right there. Yeah.
We were
Ah.
talking to people last week, Adam, about vaccine hesitancy, people from African and Caribbean communities, and it was one of our Carmel's gigs, so she could probably tell you more about it. But they were keen, they were clear about how information is given out, and it should be them that's passing the information on to other people in their communities in a way that they want to hear it and will understand it. Because we did talk about, you know, the difference between getting sick after you've had a COVID vaccine and getting sick after you've had Weetabix for breakfast, and which one do you blame?
Yeah.
And you always make the link to the vaccine, but you never make the link to the bad fish you had the day before or something. And it's that kind of message,
Yeah.
you know, we need to get across, and they'll be working with Carmel and those groups of people, I'm sure will hopefully will help.
Yeah, and it's work that, you know, I've been saying this for 15 years, that the challenge in the 21st century, in order to maximize the benefits that we can get from vaccines, is not lack of vaccines, it's lack of trust. You know, you can have the best vaccines in the world, but if they don't end up inside people, they don't do anything. And so, you know, that's the main challenge here, I think, is, and that's why this kind of program cannot be being done by old white men in universities thinking away and having ideas like me. They've got to be being done by young non-white women talking to the people who really will believe and trust them. Because, you know, with full knowledge and understanding, they're not just the messengers, they need to own the project, if you like, and be part of the team in a full-blooded way. That's really where we want to go with this. And I think, you know, not only can we discover interesting things, but we can also change a culture in some ways. What I've observed with pediatric vaccination over the years is that you do build a culture of research. So initially you go to families and say, well, can we study your newborn baby, take blood from them, give them vaccines? People are a bit nervous about that. Now we have people ringing up saying, oh, we've just had another baby. Have you got a study going on that we can do? So, you know, that's what you're trying to do, is you're trying to build a culture where, you know, the team isn't just a bunch of academics. It isn't just a bunch of health professionals. It's the whole community. Everyone's bought into it. And that's what I was trying to achieve with this, really.
You'll be pleased to know I'm taking part in a vaccine study from next week. The UTI, urinary tract infections in men over 60.
Fantastic. Yeah, that's a very interesting study as a Janssen vaccine, and actually groundbreaking stuff, actually. We've never had any vaccine for that whole area of medicine up till now. So very important piece of work. Great. I'm glad.
And I was actually suffering from a urinary tract infection when I saw the tweet. Somebody tweeted that this study was beginning for men over 60 who'd had a urinary tract infection in the previous 2 years. So I thought, okay, that's me now.
Well, there's a good example of social media being good. You know, I was slapping them off earlier. Of course, they have, you know, certainly earlier on in the pandemic, there were real opportunities to use social media to get people on board. Both broadcast media, but also social media, and we got a lot of response that way too.
You just got to read the replies.
Yeah, I was tweeting stuff. A number of people who follow me on Twitter, Twitter's going to exist very much longer, but at least there were quite a few Bristol people. And then if I put something out saying all Bristol people, they would then kind of disseminate out because other people would have their own local networks, and that worked really well.
Can I ask a couple of points, Adam?
Yes, please.
Yeah. So the two things that just occurred to me, you mentioned consent. I think the patients have got to be consented. I think they have got to give consent for this.
Well, interesting that you should say that, because that's absolutely not the case.
Really? Wow. Okay.
So the whole thing is that for a real world implementation, you absolutely can't have consent, because then it wouldn't be real world implementation anymore. You would end up exactly excluding all of those people who don't
understand that.
So we wouldn't find anything out at all that would be of any use. But you are right in a sense, and that is that the surveillance side of it, where you're gathering the data or even additional samples, is definitely, it needs ethical approval. We have very detailed approvals from both the MHRA and CAG, which is the Confidentiality Advisory Group, so that we can legitimately collect data from people, anonymize it so that when it goes through to analysis and is ultimately shared with the commercial sponsor, it's all completely untraceable as to who's being talked about. And of course, we're collecting additional samples to look for viruses and so on. And all of that has to be done with consent. So in terms of the surveillance side of it, both in primary care and in the hospitals, there's a very clearly regulated consent process because of the confidentiality of data and the fact you're doing additional sampling and so on. But the actual implementation of the vaccine, it's a licensed vaccine, it would have to be just run out through the local NHS. Of course, you'd have the same level of consent as you would always have for clinical practice. Nobody's required to have a vaccine unless they want it, and they have to agree to receive it. But that would be the level. It wouldn't be a research ethics consent. And if we went to an ethics committee with this, they'd say, well, hang on, you're just implementing a vaccine here. That's not research. So the research bit.
Okay.
Yeah.
Okay. The other point I just had is, so is this FDA approved and MHRA approved, or where is the approval for this? If we're talking about phase 3 here, presumably phase 3 trials have been conducted elsewhere.
So for us to be able to do this work, it would have to be MHRA approved.
Right, okay.
We wouldn't need regulatory approval in the US or in Europe anymore because of Brexit.
Okay.
But generally speaking, these things get approved by FDA and EMA before MHRA approval comes through. So it's quite likely that because the market in the North America is the most lucrative one. So the companies prioritize the authorization in that market, generally speaking, for all their products. But you could conceivably imagine that there would be MHRA approval. After all, with the first approval of any COVID vaccine was MHRA approval back in November of 2020. So it could conceivably happen. But anyway, in order to be able to do it in the UK, you would need MHRA approval.
Okay, thank you for that.
So are there any other comments or questions for Adam?
Just one other thing, Adam. So you're talking about a winter rollout. I assume there's no question of being able to do it as soon as this winter, is there?
No, what we're doing this winter is we are already doing this surveillance, as I mentioned. So we will be able to be evaluating the current vaccine. So we've got a continuous rolling program of COVID vaccine evaluation. Some really interesting data just coming through this week on the new bivalent vaccines. And then there'll be lots of people receiving both flu vaccine and there's a pneumococcal 23 valent vaccine that's been given for many years, the effectiveness of which is in doubt. So we'll be able to provide information on that. But in terms of this program, we're applying for this fellowship now. The MHRA is not very quick, so we'll not get an answer to that until sometime next summer. So at the very best, we'd be able to conceivably do this by next winter season, if things, if everything falls into place on time. But we are reasonably confident that we'll be able to carry on our surveillance, at least in the hospital, through next winter, even if this implementation program doesn't get started in time for that. So that because what we don't want to do is have the whole machinery having, we've got about 80 or 90 people doing this. If it all got shut down, it would take a long time to get it all started up again. So we want to keep it going so that we can then do this kind of work as and when, as soon as it can be organized.
Thank you.
Sure.
I've got one question for Carmel. Would this be a video? Now you've recorded this, would this be something we could share with the people we were speaking to last week? Maybe see if they're interested in seeing it, because I think it answers a lot of questions.
Could be. Definitely could be. Yeah, let me have a think about it. If you were happy, Adam, for me to share this.
No, I'd be very, very happy. I think it was a very, very useful discussion for me. And if it would be interest to other people and maybe stimulate other comments or suggestions, even if they, arrived a bit later in writing or whatever, that would be really helpful to us.
Okay, good idea, Mike. And because, we were looking at the project's a systematic review, looking at interventions to increase vaccine uptake. So Claire French is leading on that. And it was, we had quite a diverse group, didn't we, of public contributors. So it's a good idea. We'll do that then.
Brilliant. Good. Well, please encourage people to drop me an email or any comments, you know, whether it came back through you, Carmel, or directly, whatever, would be really useful for us.
Brilliant. Well, I will let you enjoy the rest of your day, but thank you ever so much again, Adam. And Sarah, thank you so much for coming. And if there's anything else you think of after, please do send it to me, any reflections, and I'll pass it on to Adam.
Well,
Great.
I'm just in favour. I really hope it happens.
Thanks, Sarah. I really appreciate your comments. So thanks, Mike, and thanks, Carmel.
Okay.
I really appreciate
Nice
it.
to see you, Adam.
Yeah, all right. Take care.
All right, bye-bye.
Bye now, everyone. Bye.
Bye, Sarah.